Structure, function, and disorders of the integument. The skin is composed of three primary layers: the epidermis, the dermis, and the hypodermis. The epidermis is the thin, outermost layer responsible for protection and barrier function. Beneath it lies the dermis, which houses blood vessels, nerves, and connective tissue. The deepest layer, the hypodermis, contains fat and connective tissue that insulate and cushion the body. This slide presents histological images of the skin from various sources. Notice how the epidermis forms the thin outer layer, while the dermis below provides structural support and houses sensory and vascular components. The hypodermis lies deepest, rich in adipose tissue and large blood vessels, providing insulation and shock absorption. Dermal appendages are specialized structures found within the dermis. These include hair follicles, sebaceous glands, nails, and both acrine and apocrine sweat glands. Each plays a role in thermoregulation, waste excretion, and protection. The dermis also contains papillary capillaries, which nourish the epidermis. Nails are modified keratin structures that protect the fingertips and enhance fine motor function. They grow from the nail matrix under the cuticle and consist of tightly packed, keratinized cells. Healthy nails are a visible indicator of nutritional and systemic health. Nail changes can signal underlying conditions ranging from anemia to chronic disease. Primary lesions are the initial signs of a pathological skin process. These include macules, papules, nodules, plaques, wheals, vesicles, and pustules, among others. Recognizing and describing primary lesions is essential for accurate diagnosis. Each lesion type reflects a different underlying cause, from infection to autoimmune disease. Secondary lesions evolve from primary lesions or result from external factors like trauma or infection. Examples include scales, ulcers, scars, and fissures. These lesions often indicate the stage or chronicity of a skin condition. Careful observation helps guide treatment decisions and monitor disease progression. Pressure ulcers are localized injuries caused by prolonged unrelieved pressure on the skin. They often occur in individuals with limited mobility. Risk factors include pressure, shear forces, friction, and moisture. These ulcers can range in severity from superficial redness to deep tissue destruction. These ulcers commonly develop over bony prominences like the sacrum or heels. Prolonged pressure restricts blood flow, damaging capillaries and leading to tissue ischemia. Over time, cellular injury leads to necrosis and skin breakdown. Even soft tissue can be affected if pressure is sustained. Prevention is critical in managing pressure ulcers. Key strategies include frequent repositioning, pressure-relieving devices, and moisture control. Early detection through skin assessments can halt progression. Nursing care plays a vital role in reducing incidence and promoting healing. Pressure ulcers can become severe and lead to systemic infections if not properly treated. Early intervention includes offloading pressure, cleaning the wound, and addressing underlying health issues. Nutrition and hydration are also vital for wound healing. Multidisciplinary care improves patient outcomes significantly. Keloids and hypertrophic scars both result from excessive collagen production during wound healing. Keloids are raised, firm scars that extend beyond the original wound borders and may recur after removal. Hypertrophic scars are similar but remain confined to the wound area. Both types can cause discomfort and cosmetic concern. This image shows a keloid characterized by its elevated, claw-like growth extending past the original injury site. Keloids are more common in people with darker skin tones and can develop after minor injuries. Treatment may include corticosteroid injections, silicone sheets, or surgical removal. However, recurrence is common and prevention is key. Pruritus, or itching, is one of the most distressing symptoms of skin disease. It can result from primary skin disorders, systemic diseases, or even neurological causes. Itching is transmitted by unmyelinated C nerve fibers, which also interact with pain pathways. Persistent pruritus can lead to scratching, causing secondary skin damage. Eczema and dermatitis are broad terms used for common inflammatory skin disorders. These conditions present with itching, redness, and indistinct lesions that may become thickened or leathery over time. Chronic scratching worsens symptoms and can lead to hyperpigmentation. Identifying triggers is essential for long-term management. Allergic contact dermatitis is a delayed hypersensitivity reaction mediated by T cells. It begins when an allergen binds to skin proteins, forming a complex that sensitizes the immune system. Symptoms include redness, swelling, itching, and vesicles. Common allergens include nickel, poison ivy, and fragrances. This slide displays visual examples of allergic contact dermatitis. Lesions may appear as grouped vesicles or erythematous patches on exposed skin. Diagnosis is based on history, clinical presentation, and sometimes patch testing. Avoidance of the allergen and topical corticosteroids are mainstays of treatment. Irritant contact dermatitis is caused by direct damage to the skin from chemical or physical irritants. Unlike allergic dermatitis, it doesn't require immune sensitization. The severity depends on the concentration of the irritant and duration of exposure. Symptoms are similar, but often more localized and immediate. Atopic dermatitis, or allergic eczema, is a chronic condition often seen in individuals with asthma or hay fever. It is associated with elevated IgE levels and family history. The skin becomes dry, itchy, and inflamed, especially in flexural areas. Management includes moisturizers, antihistamines, and topical steroids. Stasis dermatitis typically affects the lower legs and results from chronic venous insufficiency. Pooling of blood and fluid leads to skin changes like redness, itching, scaling, and eventually ulceration. Over time, the skin becomes thickened and discolored. Compression therapy and skin care are crucial to prevent complications. This slide includes images of stasis dermatitis. You can see the hallmark signs of hyperpigmentation, erythema, and scaling around the lower legs. These changes develop gradually due to chronic venous pooling. Left untreated, this condition can progress to venous ulcers. Seborrheic dermatitis is a chronic inflammatory skin disorder that typically affects areas rich in sebaceous glands. Common locations include the scalp, eyebrows, nasolabial folds, and chest. In infants, it presents as cradle cap, and in adults, as scaly, greasy patches. Treatment includes antifungal agents and mild corticosteroids. This image shows typical seborrheic dermatitis of the scalp. The lesions appear yellowish or white, with a greasy scale over red or inflamed skin. While not dangerous, the condition can be cosmetically distressing. Regular treatment helps reduce flares and discomfort. Psoriasis is a chronic, relapsing skin disease involving immune system dysregulation. It is marked by overactive T cells, dendritic cells, and cytokines that cause rapid skin cell turnover. The result is thick, red plaques covered in silvery white scales. Psoriasis affects quality of life and can also involve the joints. In psoriasis, the normal epidermal turnover cycle shortens from 14 to 20 days to just 3 to 4 days. This rapid proliferation prevents proper maturation of keratinocytes, leading to the buildup of immature skin cells. These form characteristic plaques that are itchy and may crack or bleed. Triggers include stress, infections, and certain medications. This clinical image shows classic plaque psoriasis, raised, red, scaly patches commonly found on the elbows, knees, and scalp. Psoriasis may also affect the nails or present with pustular or inverse patterns. Diagnosis is usually clinical, but biopsy may confirm the diagnosis in unclear cases. There are several forms of psoriasis, including plaque, inverse, gutted, pustular, and erythrodermic types. Some patients may also develop psoriatic arthritis, which affects the joints. Psoriasis can involve the nails, causing pitting or discoloration. Each subtype varies in presentation and severity. Pityriasis rosea is a self-limiting inflammatory skin disorder that often begins with a single, large lesion called a harrow patch. Within days, smaller, salmon-colored lesions spread across the trunk in a Christmas tree pattern. It typically resolves within 6 to 8 weeks without treatment. Antihistamines or topical steroids may help control itching. Lichen planus is a benign, autoimmune condition affecting the skin and mucous membranes. It presents with purple, flat top, polygonal papules, often with fine white lines called Wickham striae. The condition is intensely pruritic and may also affect the mouth and genitals. Triggers include medications and hepatitis C infection. This image highlights the violaceous lesions of lichen planus. Oral involvement may appear as white patches on the buccal mucosa. Lesions typically resolve over time, but may leave behind discoloration. Topical corticosteroids and immune-modulating therapies are commonly used for symptom relief. Acne vulgaris is a chronic inflammatory disorder of the pilosebaceous unit. It most often affects adolescents and young adults. Acne involves clogged pores, bacterial overgrowth, and inflammation, leading to comedones, papules, pustules, or nodules. Severe cases may result in scarring and require systemic treatment. Acne rosacea is a chronic skin condition seen in adults, especially those with fair skin. It causes flushing, telangiectasia, papules, and sometimes ocular symptoms. Triggers include sun exposure, alcohol, and spicy foods. Unlike acne vulgaris, it doesn't involve comedones and is treated with topical or oral anti-inflammatories. Lupus erythematosus is an autoimmune disease with both systemic and cutaneous forms. Discoid lupus is a localized skin manifestation, often presenting with photosensitive, scaly, disc-shaped lesions. The classic butterfly rash appears across the cheeks and nose. Sun protection and immunosuppressive therapy are key in managing the condition. This image displays characteristic skin findings of discoid lupus. Lesions may persist for months and can result in scarring or atrophy. They often worsen with sun exposure. Early treatment improves outcomes and minimizes permanent damage. Pemphigus is a rare autoimmune blistering disease affecting the skin and mucous membranes. It's caused by antibodies that attack desmosomal proteins, which help skin cells stick together. This leads to flaccid blisters and skin erosion. Diagnosis involves biopsy and immunofluorescence studies. This slide presents an image of Pemphigus vulgaris. The blisters are fragile and often rupture, leaving painful erosions. Oral mucosa is commonly involved, which can interfere with eating and speaking. Treatment includes corticosteroids and immunosuppressive agents. Erythema multiforme is a hypersensitivity reaction marked by target-shaped lesions with concentric rings. It often follows infections or medication exposure. The condition may involve mucous membranes, causing difficulty swallowing, breathing, or urinating. Most cases resolve spontaneously, but severe forms may require hospitalization. Stevens-Johnson syndrome and toxic epidermal necrolysis are severe mucocutaneous reactions to medications. They are considered medical emergencies. Patients develop painful bully, mucosal erosions, and widespread skin sloughing. Management involves immediate withdrawal of the offending agent, supportive care, and often ICU admission. Common bacterial skin infections include folliculitis, furuncles, carbuncles, cellulitis, and erysipelas. These infections typically involve Staphylococcus aureus or Streptococcus pyogenes. They present with redness, swelling, warmth, and pain. Prompt antibiotic therapy is important to prevent complications. This image shows a furuncle, also known as a boil. It's a painful, pus-filled nodule arising from a hair follicle. Multiple furuncles may coalesce into a carbuncle, often requiring drainage. Hygiene, warm compresses, and antibiotics are the mainstays of treatment. Impetigo is a superficial skin infection caused by Staphylococcus aureus or beta hemolytic streptococci. It presents as honey-colored crusted lesions, often around the nose and mouth. It's highly contagious, especially among children. Prompt treatment with topical or oral antibiotics prevents complications and spread. Herpes simplex virus HSV includes HSV1 and HSV2. HSV1 typically causes oral lesions, while HSV2 is more associated with genital infections. The virus causes clusters of painful vesicles on a red base and is transmitted by direct contact. After initial infection, the virus remains dormant in nerve ganglia and may reactivate. Herpes-Zoster or shingles and varicella or chickenpox are caused by the same virus, Varicella-Zoster virus. After chickenpox resolves, the virus stays latent in nerve roots and can reactivate later as shingles. Shingles causes painful, unilateral vesicular rashes, often in a dermatomal pattern. Antiviral treatment can reduce symptoms and duration. Warts are benign skin growths caused by the human papillomavirus HPV. They appear as rough, raised papules, commonly on the hands or feet. Plantar warts develop on the soles, while condylomata acuminata are genital warts transmitted sexually. Treatments include topical therapies, cryotherapy, or surgical removal. Fungi that infect the skin, hair, or nails are called dermatophytes. These superficial fungal infections are referred to as tinea. Depending on the location, the condition is given different names, such as tinea capitis or tinea pedis. Diagnosis often involves a skin scraping for microscopic examination. Tinea infections are named by the area affected. These include tinea capitis, tinea manis, tinea pedis or athlete's foot, tinea corporis or ringworm, tinea cruris or jock, itch, and tinea unguium, also called onychomycosis, which affects the nails. Lesions are often red, scaly, and may have a central clearing with an advancing border. Treatment includes antifungal creams or oral agents. This image shows tinea pedis, a common fungal infection affecting the feet. It causes itching, peeling, and cracking of the skin, especially between the toes. Moist environments like locker rooms or tight shoes promote fungal growth. Antifungal creams and good foot hygiene are key to treatment and prevention. Candidiasis is caused by Candida albicans, a yeast normally found on the skin and mucous membranes. It becomes pathogenic in moist environments or when the immune system is weakened. Risk factors include diabetes, antibiotic use, pregnancy, immunosuppression, and infancy. It typically presents as red, itchy patches with satellite lesions. Cutaneous vasculitis is inflammation of the blood vessel walls in the skin, often triggered by immune complex deposition. It can result from infections, medications, or allergens. Lesions begin as palpable purpura and may progress to necrosis or ulceration. Treatment focuses on managing the underlying cause and controlling inflammation. Urticaria, or hives, is a skin reaction caused by histamine release during a type I hypersensitivity reaction. It results in raised, red, itchy welts that may come and go rapidly. Common triggers include foods, medications, insect stings, or allergens. Most cases resolve within 24 hours, but antihistamines can speed relief. Scleroderma is a condition involving abnormal collagen buildup in the skin and sometimes internal organs. The localized form affects only the skin, while the systemic form may impact the lungs, kidneys, or heart. Early signs include shiny, tight, hardened skin and Raynaud's phenomenon. Over time, the skin may become immobile and lead to joint or organ dysfunction. This image shows advanced cutaneous scleroderma with characteristic smooth, stretched skin. In systemic cases, patients may also develop esophageal dysmotility and renal crisis. Diagnosis involves antibody testing and clinical signs. There is no cure, but immunosuppressants and symptom-targeted treatments can help. Benign skin tumors include seborrheic keratosis, keratoacanthoma, actinic keratosis, and nevi. Seborrheic keratosis appears as waxy, stuck-on plaques, often in older adults. Actinic keratosis is a precancerous lesion that arises from sun-damaged skin. Nevi, or moles, may be pigmented or skin color and are usually harmless unless they change in shape, color, or size. This slide shows seborrheic keratosis, which presents as a brown, wart-like lesion with a rough, uneven surface. It may look alarming, but is benign. These growths do not require removal unless they become irritated or for cosmetic reasons. If diagnosis is uncertain, biopsy may be performed. Basal cell carcinoma is the most common skin cancer worldwide. It grows slowly, rarely spreads, and often appears as a pearly nodule that may ulcerate. Sun exposure is the primary risk factor. Early detection and removal typically result in a full cure. Squamous cell carcinoma arises from the epidermis and is the second most common skin cancer. It may begin as actinic keratosis and can appear as a scaly, red patch or firm bump. While it's less likely to spread than melanoma, untreated lesions can become invasive. This slide shows visual comparisons between different types of skin cancer. Recognizing visual patterns, such as ulceration, irregular borders, or color changes, can aid in early identification. A biopsy is required for definitive diagnosis. Melanoma is a dangerous skin cancer that originates from melanocytes and has a high risk of spreading. It often develops from a mole and follows the Apsidae rule: asymmetry, border irregularity, color variation, diameter over 6 millimeters, and evolving. Kaposi sarcoma, on the other hand, is a vascular tumor often linked to HIV or immunosuppression, presenting as purple, red, or brown patches. This slide displays clinical images of cutaneous melanoma and Kaposi sarcoma. These conditions require urgent referral to dermatology. Treatment may involve surgery, immunotherapy, or chemotherapy depending on severity. Primary cutaneous lymphomas are rare cancers that begin in the skin's immune cells. They include both T-cell and B-cell lymphomas, with mycosis fungoides being the most well-known type. Lesions may look like eczema or plaques and often progress slowly. Diagnosis relies on biopsy and immunophenotyping. Burns are categorized by depth. First-degree burns affect only the epidermis and cause redness and pain. Second-degree burns go deeper into the dermis and may form blisters. Third-degree burns destroy the full thickness of skin, and fourth-degree burns extend into muscles and bones. These slides show burn severity and how to estimate total body surface area using the rule of nines or the Lund and Browder chart. This helps guide fluid resuscitation and treatment decisions. Burns covering more than 20% of the body are considered major injuries requiring hospital care. Fourth-degree burns are the most severe, destroying not just the skin, but also underlying muscle, tendon, and bone. These injuries are often life-threatening and require extensive surgical intervention. To assess the extent of a burn, providers use tools like the rule of nines and the Lund and Browder chart. These help estimate total body surface area affected and guide fluid resuscitation. This slide provides visual examples of burns at different stages and depths. Recognizing the appearance and tissue involvement is essential for classifying burn severity. Proper classification ensures appropriate treatment decisions, especially in emergency settings. Burns covering more than 20% of total body surface area are considered major injuries. These result in significant fluid loss, electrolyte shifts, and protein leakage into tissues. Burn shock can occur, marked by reduced blood volume and impaired circulation. Rapid fluid replacement is vital to prevent organ failure. The hallmark of burn shock is a drop in cardiac contractility and cardiac output, leading to inadequate perfusion. Plasma and proteins leak out of blood vessels, raising hematocrit levels and lowering protein. This sets the stage for hypovolemia and edema. If left untreated, irreversible shock and death can occur. After a major burn, the body enters a prolonged hypermetabolic state, often referred to as the flow phase. This leads to increased body temperature and a high demand for calories and nutrients. Inflammatory cells are recruited to the site of injury, intensifying the response. This metabolic surge can last for months. Burn injuries trigger a powerful immune reaction, but it often results in immunosuppression. White blood cell function becomes impaired, and inflammatory cytokine surge. Both cellular and humoral immunity are disrupted. This puts patients at high risk for infections and sepsis, the leading cause of burn-related death. With the skin barrier compromised, burn patients lose large amounts of water through evaporation. Hypermetabolism and increased breathing also increase fluid loss. Without replacement, dehydration and electrolyte imbalances can develop quickly. Maintaining hydration is a cornerstone of burn care. Deep partial thickness and full thickness burns take longer to heal and often result in scars and contractures. Wound healing is complex and may take weeks to months. Contractures can limit movement and require physical therapy or surgery. Early wound closure is essential to improve outcomes. Survival after major burns depends on a few critical interventions. These include early and adequate fluid resuscitation, high-calorie nutrition, timely wound closure through surgery or grafting, and prevention of infection. Close monitoring and supportive care are crucial, especially in the first few days. This slide includes real-world images of burn injuries and surgical grafting techniques. These visuals help reinforce the importance of early intervention, sterile technique, and proper surgical planning. Burn units often use a team approach for best outcomes. Here we see examples of skin grafts, healing stages, and scar patterns. These images show how complex and prolonged burn recovery can be. Pain control, rehabilitation, and emotional support are just as important as the surgical aspects of care. The final slide on burns reinforces the diversity of presentations and healing outcomes. It's a reminder that burn care goes far beyond initial treatment. It requires a long-term, multidisciplinary approach. The ultimate goals are survival, function, and cosmetic recovery. Cold injuries occur when skin and underlying tissues are exposed to freezing temperatures. Frostnip is the mildest form, where the skin turns pale and numb without permanent damage. Chilblain, on the other hand, causes painful, itchy, purple plaques or nodules due to repeated cold exposure. These early-stage injuries are often reversible if treated promptly. Frostbite happens when skin and deeper tissues freeze, forming ice crystals inside cells. Initially, there's no pain, but once tissues start thawing, pain becomes intense. The injury is classified based on depth, ranging from superficial to deep involvement. Flash freeze injuries can occur instantly when skin touches extremely cold metal or liquid, causing rapid intracellular freezing. Alopecia refers to hair loss that may occur on the scalp or body. One common type is androgenic alopecia, which is hereditary and linked to hormone sensitivity. It affects up to 80% of men and a significant number of women. The pattern of loss depends on whether the follicles are androgen sensitive. In female pattern alopecia, hair thins over the central scalp, but the frontal hairline is typically preserved. It progresses gradually and may be influenced by genetics, hormones, and aging. Unlike male pattern baldness, women don't usually develop complete baldness. Treatment options include topical agents, hormone therapy, and hair restoration procedures. Alopecia areata is an autoimmune condition where the body attacks its own hair follicles, causing sudden, patchy hair loss. It can affect the scalp, eyebrows, or any hair-bearing area. Hirsutism is the opposite concern, excessive, male pattern hair growth in women. It's often related to hormonal imbalance, particularly elevated androgens. Nail disorders can be caused by infection, trauma, or systemic disease. Paronychia is an infection of the nail fold, typically caused by bacteria or yeast. Onychomycosis refers to fungal infection of the nail plate, leading to discoloration, thickening, and brittleness. These conditions often require antifungal or antibacterial treatments and good nail hygiene. As we age, our skin becomes thinner, drier, and more fragile. There's a natural decline in collagen, elastin, and the number of melanocytes, leading to wrinkles, uneven pigmentation, and slower healing. Oil and sweat gland activity also decrease, contributing to dryness and increased risk of skin injury. These changes make elderly skin more vulnerable to infections, tears, and pressure ulcers, making gentle care and hydration essential.